Okay,
Ladies
ladies
and
and
gentlemen, we
gentlemen, we
want
want
to
to
start
start
this
this
section
section
right
right
away.
away.
Would
Would
pass
pass
the
the
baton
baton
to
to
the
the
chairman
chairman
who
who
will
will
give
give
an
an
opening
opening
remark.
remark.
Then
Then
we
we
will
will
take
take
the
the
presentation.
presentation.
You're
You're
all
all
welcome.
welcome.
Let's
Let's
appreciate the
appreciate the
chairman,
chairman,
please.
please.
So I hear Mr. Abdul is around. He will soon join us, please. Once again, the title of this section is Strategies for Combating Stigma through Community-Led Intervention and Engagement. Madam, is somebody in touch with Abdul now?
Surrounding HIV/AIDS through community-led monitoring, interventions, and engagement. So now we all know about 95, 95, 95, which focuses on treatment. We all know resource mobilization, but in the focus also on what is known as societal enablers, and they've got three targets called talking about community-led monitoring, this should read community-led interventions and also community-led.
Be able to read from the slide. Good afternoon, distinguished ladies and gentlemen. It is my pleasure to come to give an overview of the use of the community-led monitoring in combating HIV intervention in Nigeria. Next slide. Who is controlling the computer? Okay. So, just by way of introduction, uh, I want us to open our minds because the community-led monitoring is a combined approach. So these give opportunity to involve different communities, the youth and the key population. And I'm glad my brother here, Anedi, even though we have not greeted, is leading the community-led monitoring aspect of people who use drugs, and they have gone far to also have a framework. And I'm glad to also share that we are now working integrating the framework so that we have similar indicators that we monitor, and also one harmonized framework that is acceptable by all parties implementing or using CLM to provide services. Also improve program effectiveness. This is talking about how CLM helps identify gaps and opportunities for improvement in HIV prevention program, leading to more targeted and effective interventions. Some of you will agree with me this morning. Uh, Kumi talked about funding opportunities for targeted program. It all emanates from our community feedback using the community led monitoring interventions, where we provide feedback from the youth groups through our quantitative and qualitative analysis, where we're able to generate information specifically from this targeted population. It has also helped in advocacy and with the need of this specific group, which has really helped in becoming something that led to the Ambassador Kenderson approve some amount of money to be given to the youth-led organizations and led specific intervention, which was announced. It also increased trust. CLM foster trust and collaboration between communities and health systems, resulting in better outcomes of prevention services and improved outcome. Next slide, please. So the next slide talks about the target groups of the population that targeted in the CLM implementation. One of them is the PLHIV communities. We also have the key population. I mentioned the typologies. We also have women and also um, people with TB, and also people within the uh, most at risk of contracting HIV, people within closed settings, like the prisoners and co. So we extend some of these interventions actually. So next slide. Okay, so the key component of the community-led monitoring, I skipped the framework at the initial uh, stage because it's not even clear. But the most important thing is about the outcome that it provides. And we focus on four major building blocks. One, it is the empowerment I talked about, which is education. We also have evidence. Using the evidence about generating data so that whatever you are talking, you should be able to speak to data. When you talk with data, remember earlier this morning, different speakers were putting uh, different numbers, people on treatment, and all of that. Some are quoting from the 2018 NICE survey, but our program has been improved through UNA and also NASCAP through the Ministry of Health. So we have a lot of review, and recently even NACA conducted what they call getting the data survey, which has also helped to evaluate total number of people on treatment and our estimation. We also have advocacy and engagement. So these four are the four main, blocks around the CLM education, evidence, advocacy, and engagement. And the advocacy, it provides opportunity and resource for communities to create solutions and enable targeted action at local, national level. Because the CLM is being implemented at the community. So in the course of the presentation, I will read where we are now. advanced, and we are now using an application where you see the beauty around that. And then the engagement is basically engaging key stakeholders and influencers to ensure that whatever issues that have been brought to the table is being addressed. So that's just the around CLM and the consent. Next slide. Now, this one is the steps in implementing the community. No, no. Next slide, please. Okay. So the steps are as follows. You have the community mobilizations and engagement. You will all agree with me when you are talking of HIV prevention, now that the strategy is around prevention. One of our major keys is about this engagement and community mobilization, where community members are engaged and stakeholders to build partnership and identify priorities for HIV prevention. So it's through dialogue and engagement. Sometimes when you go to community, uh, you, for example, now you want to sell prep. Some people may not really have deep understanding about what prep is, but you can also provide an option, maybe like use of condom and other means like abstinence and code for all those preventive measures. So it's a choice, but it's important is to be able to mobilize people and engage them around all the options. So this one is one of the things that we follow. That then we have the capacity. It provides training and resources to empower community members to participate effectively in monitoring activities, not only implementing, but also they need to monitor and ensure quality of these services are being provided, not only by community members, but by our healthcare providers, because we also do go to communities and within our facility setting. Then we have data collection and analysis. So this is to collect relevant data, just like I have mentioned about the data. So the relevant data are being gathered and using participatory method analyze to inform decision making. So this is just the beauty around the data. If you collect it, then you also need to analyze it. So when you analyze it, will give you critical analytical aspect and from different groups ranging from the AGYW, the key population, and the PLHIV. Just like I have said, this is just to give us an overview, but we have the overall report of what we have implemented in the papers. And if you need that, a poster is available, share that with you. Then advocacy. These are all the building blocks I have explained earlier, and then feedback and continuous improvement. So this has to be the continuous engagement, so that if, for example, we said we don't have particular commodities and it's being provided, we need to sustain, especially procurement. If you procure today, maybe you procure test kits. It's also key in HIV prevention because people need to know their HIV status to be able to know whether they are infected or not. Am I communicating? So these are some of the tools that we use to remind government and our partners around our contribution in HIV prevention in Nigeria. Next slide, please. So the next slide is still talking about uh, the framework and also the approach. If you look at it, we have data collection both within the facility and community. Then you can translate the data into actionable insight. Then bring the information to the attention of decision makers. Then advocate for changes in policies and practices. For example, these policies, there are a lot of policies, especially that is a concern to us that limiting key populations community come out to access service. Sometimes they are being harassed by the police. We have a tool that gives a group of individual an opportunity to report some of these things independently using our eye monitor approach that help us to gather information, and it helps us to gather what is really happening. And sometimes you only know this is coming from a particular zone or location, but you won't even know who is reporting. So these are some of the confidentiality we are also building using the CLM approach. Then and finally to monitor the implementation and also the promise. So these are some of the engagements. So just to explain to you in different ways how the CLM operates. So these are some examples of the community-led monitoring initiatives. The CLM led HIV education outreach campaign targeting key population, resulting in increased awareness and behavior changes. Why you see this, the key population today are the most potential, if I may say, where the HIV intervention is growing rapidly. So, in our own effort, we collaborate and work with everybody, even though we are people living with HIV, but among that community, we understand and also know a large number are also living with HIV, and it's the same services they are being provided. But what we expect most importantly is about their dignity and their way of life, and it must be respected at all costs. And our effort, we ensure that that full integration also happens in NEP1 and these other sub-groups, because we have approved by the board to also integrate some of this group, whoever that wants to join NEP1. And I'm glad to report to you that we have registered a quite number of population support groups with certificate, both at national and state. For example, in Cross River, places like Lagos, even in my state, in Sokoto, we have registered them, and now they are even accessing global fund through our community-led responses. I know it is a big journey, but gradually we are going through partnership. Then peer-led income distribution and HIV testing initiatives in improving access to prevention services among vulnerable populations. So all these are some of the key things that we do at the community level as part of our community-led responses engagement. And we also do community-led research projects to assess the effectiveness of HIV prevention interventions, informing program decision and implementation. Okay. So these are just examples of these how the CLM work. Next slide. I will be very brief because of the time. This one. So this is the tool that I want everybody to pay attention to. This tool is called iMonitor. We have a link. We will share with you. Efosa, please share with everybody. Share with the conference secretariat to make it available to people. Let them see what we are doing, and also share with other community members. So what the iMonitor is using is a partnership that is being developed through a foreign partner. It's called Dure Technology. They are experts and they are based in Geneva. They work closely with the Global Fund, and the essence of that is to empower the voice of the communities affected by HIV and AIDS, and to keep them at the center of health response. This this app, you can download it on your phone, and it has different domain on the dashboard. So anything you want to monitor or you want to report is available. And you could also use it to locate where you will get access to any service anywhere you are in Nigeria. And we are now moving to also bring in other things that are not there, because it's a continuous thing, and it gives opportunity to review and bring in new things that we also need to monitor at a particular time. Using the iMonitor, CLM uh, is digitalized to support the communities at individual level and also at the community level. So this is just an overview of how the app looks like and work. Once you tap in, it will just analyze everything for you and give you the percentage any problem. You don't need to go to Excel to do all of that. It gives you the percentage ratio and the total number of people who access so easily. So you could just print it and even use it for your advocacy. Next slide. So uh, just to conclude, because of time, the community-led monitoring is a valuable approach that enhances HIV prevention, and we are using this process to really generate create and also link people here and also ensure that violations are also being achieved. And it also gives opportunity to report issues around gender and human rights violations among all populations. So I think I need to stop here because of time. I thank you very much for patience. When I came in, I was feeling very hungry, and I had to run to the canteen to put something in my stomach. But thank you very much for for listening. God bless you all. And then we are available to provide feedback on any question.
Very much, Abdul. Um, please allow him to sit so that the food can digest. Now, that was a very nice presentation. Yeah, that's for prevention. We're going to open it to the floor, and if you have questions. But before we do that, let's get Madam Esther here from Ashford. If there's anything she'd like to add, or any comment before we get
Thank you very much, Chairman, and good afternoon, everyone. Um, my name is Esther Hindi, National Coordinator of Ashford Association of Women with HIV. We also achieve goal of 95 team, and based on our functional implementation of the ceremony in Nigeria, of data and reports. So data and reporting consistent with rights, there will still have and by virtue of report, we are meant to understand that more than half how is our pediatric death, how is our people, they are not working with the CLM, and then the reporting to I monitor information can be right from the grassroots because that is one more thing about I monitor. Yes, can be stigma issue, can be security and other affect silence. The good thing about it is, even if you are not on the data, not on the sales, to people to drop community housing report. One thing was Nigeria, African country, what get after using this software to report, especially the issue of stigma and discrimination, high rates. That's all things that are stopping us from achieving our goals. So reporting is very important. If you want to prevent our data, we have in this company, people that are implementing And then we also have roundtable to put it together. We can achieve this. One question are we getting, are we almost there to get 1990 target that we say, and we say to the whole, the whole of if there's anybody that says we are there, there's nobody we are not sure. How do we get there? How can we achieve that? Because I really think of us work on prevention, and I also say we cannot work on only prevention because treatment is one of the components of prevention. Those that are putting on treatment and have access to services, quality services, without any and ensure that they are working up to the those area that are responsible for achievement. All organization, let us and achieving that goal and that vision. You don't need to work with as a team and see how we achieve that.
Thank you very much. So we have heard from the two national coordinators. The floor is open for questions, comments. Please don't make a presentation. As many as possible. So maybe some yes, number one, number two, number three, number four. So let's do four first. Yes.
Okay, my name is John Tobias. I'm the national Northeast based in Gombe. I want to say that I'm excited with I monitor and the effort of NEPON and ensuring that this away so. I know that much has been done. I want to also believe that much still needs to be done. What I monitor had helped in a large scale to do is harvesting responses, reporting these responses, but coming to the area of responding to the identified gaps, we are yet to optimize our effort at that. And I want to say that for stigma reduction in Nigeria, whatsoever a faith leader tells any person who believes in that faith, he has capacity to tend towards it. Stigmatization, issues around gender, based violence, and all of that continue to happen. So my question is NEPON having any future plan looking at what the I monitor is achieving to be able to go to the community level by involving faith leaders in responding to some of the social issues that continue to impede the advancement in coping stigmatization? Is there anything in the now or the near future? Over for me. Thank you.
Yes, sir. Mary Gasho is my name from Niger State. SASCAP coordinator for Niger. For me, personally, I heard about high monitor just last week. It's a state coordinator. So my question is straightforward. Currently, who are the people actually using high monitor in our virus state? So that we will also join them and also we encourage the people that we are working with, both at facility level and community level to also buy into the program. Thank you very much.
Thank you. Number three.
Thank you very much, Abdul Kadir, for that presentation. One of the things I wanted to hear clearly are key lessons, learned in terms of how CLM is implemented and potentials for scale. The other thing is challenges. I don't know if I missed it, but is it that everything went well, and then the eye monitor, has it been used, outside of PLHIV, and what are the potentials for other community members, KPs, AYPs to actually take advantage of this? Well done for your great work.
Okay. My name is Adetunji. I'd like to please ask, in practical terms, how does the CLM strategy influence disclosure and retention in treatment as a prevention strategy? My question was, how does the CLM strategy handle disclosure and retention as part of the prevention strategy?
We are pushed for time. I'm debating. Do we let him answer? Then we do just one more round of questions. Okay.
Thank you very much. He specifically talked about eye monitor. Me, I'm glad at least most of the questions are going towards the eye monitor, because it is new things that we invent about, I can just say about 6 months now. We started using eye monitor around September, November last year, and it keeps growing. So using the eye monitor to address stigma and discrimination, we have an approach using the CLM. So eye monitor is just a tool, an app that people use to get information for learning and to also report issues where necessary. So the things that we will need to do moving forward in terms of our scaling is to identify some of these religious leaders and engage them, and to also educate and empower them with the use of the eye monitor to be able to share with their members in the congregation for users in order to combat issues around stigma and discrimination. We have elements around confidentiality and also issues around fighting stigma and some of the effect and how it become a barrier when you stigmatize somebody from accessing treatment. That is for that. Then number two, I think somebody from the other side talked about who are the people using eye monitor. Eye monitor is not specifically about people living with HIV. CLM, it is an integrated approach, and the indicators that are being used to monitor these services cut across all typologies. Just like I have mentioned in my presentation, we have a section that gives you information about people living with HIV and their needs specifically. The key population and their typologies, AGY the blue, young women and girls. So it is a joint team that is open for everybody to use. The thing that is missing is that we initiated the eye monitor usage specifically towards the end of the Global Fund grant cycle. So we just implemented from September to November, only for 3 months. And what we did is a pilot in 13 states during the last grant. They used to call those states 13 KP states. So these are the states where we implemented it, and the reports are there, and you see the beneficiaries are of those services. Then coming to Heartland Alliance, my brother, there are challenges and there are also success stories. Basically, some of the success stories around the CLM, one thing that I will mention, it has helped us when we first started CLM with support from UNAIDS during COVID and so. The government of Yobe state government, through the advocacy effort from the data drive from the CLM, has made the state government to procure test kits and laboratory equipment because they understand that they can't solely depend on donor funding to be able to serve their people. And they saw it as a critical thing. It's one of the things that we are happy. Two, the previous Honorable Minister for Health, Dr. Osagi Ehanire, using our advocacy tool, we have identified the gap around PMTCT. And one key thing that was identified is lack of test kits. And the Federal Ministry of Health, using our advocacy and pressure, has made them to approve the procurement of test kits at that time using the World Bank money. I don't know where they got the sources, but all we are after is that is an issue, and we have reported, and it has been provided to close that identified gap. Then the challenges are there. People are still learning. It enables people to have deep knowledge about adherence and even when and how to even do disclosure, not only among general PLHIV that you know, but even family members who are affected by it are also mobilized. And the iMonitor is open for everybody to have access. It has a wide range of domain and information that I think everybody is open to. So one thing that I think we need to do more is to keep educating people and make it more visible and available for people. So, of course, this is a challenge on our own part, but I am sure once we start rolling out the CLM database, we should be able to achieve that. Thank you, and God bless you all.
Maybe we can allow one more question. Now, before that, I think Niger State situation is a bit specific. Was Niger State among the 13 states of the island?
Does.
And being part of the current GC7. I think that's really then already you can have it.
Yes, so Niger State was not part of the initial CLM pilot was conducted. However, there was agreement that CLM implemented. I hope you are getting what I'm saying. And the state have been divided into three. NEM 1 will have 13 states. We have the TB network, will have 11 states, and ACOMIN, which is the malaria network, will also have 13 states. If you merge all these states together, you have 7 states of the federation. To do that, but we have not yet also still working with our technical partners to finalize our agreed indicator partner will implement it. And this is to ensure that there is no duplication overlap in what we do. So that if you are implementing malaria, you should be able to monitor TB and HIV and report it for to of integrated health system agenda.
Thank you so much. Maybe I don't get it, but I just did it, so I don't need to for the states that are not being managed by malaria comes out malaria to make sure that
this is noted. We will ensure that happens. And additionally, just to provide information, we have a model that we are using. In each state, I don't know how this current treatment will look like. In the RSSHC, what we did was to allocate number of CBUs for HIV. Okay, okay, so no problem. So we will engage with you later. Is that nice? Okay, we see after.
thank you very much.
Okay. Thanks for the beautiful presentation. From the last study, of CLM approach, and the second question is, how is CLM approach different from community-based HIV diseases?
So, CLM is largely accepted in the state where we implemented, because one of the key things before you first implement CLM, you need that Ministry of Health and also SACAS. They are duly informed. And two, we also have steering committees. And in that steering committees, our communities are involved, including government. So whatever issue it's a joint, it's more like a tax team that are managing the CLM approach in the state. So what we need to do more is to support those quarterly meetings. And at some point, we're trying to see how we can support them to be integrated in the so the issues around CLM will also be discussed.
Let me just add to what he has said. You're asking the different things of Nigeria. So, Nigeria. That's what doesn't exclude the community Nigeria, but it's more like community people for the way now. We have to minutes to say, I think the key takeaways from this.
Thank you, Abdul, extra for taking us to the and starting from prevention, to ensure the right thing to do man roll out from all and the CLM is also for advocacy and the success of our prevention program. And for us to see the success, like how many people report, people really report. So there should be a structure whereby people can confidently report any form of abuse, challenges, whereby issues like this can be taken and addressed. And we need to have a structure of that even when these are being bottom, that the proper things that these people are being done, when these issues are being reported, and then just leave. So this is something that we need to look at, things being done, that we know that all these things are happening, people are taking care of, where they go and then will be taken care of. So we need to look at this and the challenges that are across. One, expanding to expand to, we also need to do it. Not still needs to be done. Even though we say it is we are doing it, address some of those that are around.
This brings I'm going to my
Thank you so much, Sam. This section. I think speaker, co-chair, deserve a resounding hand of course. So, let's keep clapping until they take their seats. Thank you so very much. We're taking notes of key this discussion. Our plan is not to make it a talk show, but to ensure that gaps, issues, and are working ready to scale. That's the real rationale behind this conference. I think what we very good at participants, we always have a video notes for ourselves. So we're behind time for obvious reasons. We open this segment. So we're going to the next presentation, section 4, which is in Hall B. So other sections are going on currently in case you want to be part of those other sections. Please, the title for this section 4, is advancing HIV prevention strategies for people who inject drugs, a focus on harm reduction in Nigeria. I already have speakers on ground. I'll be introducing them. Let's applaud them as a high table. Dr. Salaudi. We appreciate it. Is it downstairs? Let's tell you this is where Dr. Salahuddin Jimoh. While we wait for Dr. Salahuddin, we also have a leading advocate, somebody that has actually be on the very front line in ensuring that we implement harm reduction program in line with WHO recommendation. Hello, One House, please. I forgot to just remind you that the section that just ended was supported by Sideni Group. Please, can we appreciate them, Sideni Group? Let's clap for them. They are the reason why we will help the section. Next time, if you want support, if I was there, I will begin to wonder whether I should. Can we appreciate Sideni Group, please? They have their representative in the house. If you want to know more about Sideni Groups, want to visit them, they can provide support to exactly what Sideni Group does. So as I was saying, we want to introduce the next speaker. Let's appreciate Adedi. You can't talk about harm reduction programming in Nigeria without mentioning Adedi. So let's keep appreciating. Let's make this section lively, please. Okay. So to chair this section, we have one of the leading CEOs in Nigeria as far as Senator of the state and gradually talking about another person than Dr. Andy. Let's appreciate him, please. Please, let's keep clapping. It costs money to fund this section. That is why you do this. Huh? Why did you support perhaps? Okay. His grace to support Dr. Andy in this section is His Grace Jimbo. Grace here, please. Let's keep clapping, please. So we now have Dr. Salahuddin, who is the director of the Federal Ministry of Health, the chairman of the National Harm Reduction Technical Working Group. Let's appreciate him. I will tell you why. When the issue of harm reduction is beyond, Dr. Salahuddin stood with the community and civil society organizations to make sure that we have harm reduction program running. And because of his love and commitment, Dr. Salahuddin just came back from an international trip about a week ago and was sent to one of the northern states. He heard about this shortly, and immediately, in fact, he just came from that trip and is heading straight for this conference. Please help me to appreciate this patriotic Nigerian. This man is committed to ensuring that we win the fight against HIV, particularly from the harm reduction perspective. So we have all our speakers and chairpersons of Grace, which who I understand is joining us. Okay, Grace is joining us. She was a part of that section. Let's appreciate her. Thank you. So I will be handing over to the chair and the AO who will guide this process, who would, lead us. Thank you.
Thank you so much. Thank you so much. We're very glad to be here. We are especially glad to be hosting this session already. You all know HIV prevention is something very and I feel like where it's evolving, where those
So I think we're very glad to have yeah, as well as yeah, we also have we will continue with all of that to learn more about what is happening in the country. I know there's quite a few pilots to go for it. Probably we'll listen to what happens in the country, what has happened beyond what we know. We know there are loads of policy brick walls, but we also know that there's still advocacy with regard to this sector. Not to also see my dear friend Ruby, key about us to Ruby. So, without not wasting our time, because also it's fast spent, and should be faster than normal. So probably I'll give our speakers about 5 to 10 minutes. Just keep it up very fast. Let's make sense of it, and let's know where we are. Begin with my brother and friend, who has actually been a strong advocate. We are exceptionally proud of his efforts over the years, both at the community level and at the national level, and also at the policy level. So let's put our hands together as I welcome Anidia Pan to present. Really, you have to go up. You want to go up? You can present. Okay. Please, a round of applause till he gets there. Let's encourage him. I think he's quite an advocate. And welcome my co-chair, Grace, who will take over after a bit. Thank you, Grace.
Right. Good afternoon. And I didn't go to eat like I you, you forgive me if I'm a little bit calm. All right. I'm Nadia Kwan. I am someone with experience. I currently represent the community drugs as a person. Nigeria Drug User Network, registered in Nigeria as drug Nigeria. I also am the team lead for drug harm and drug free and preventive health organization. It's a drug user led community organization providing reduction services to people who use drugs. And today I'll be talking about advanced HIV prevention strategies for people who use drugs. I prefer using the term people who use drugs because it's more inclusive of people who use drugs, other people who use drugs for other routes. And the focus is on harm reduction in Nigeria. Thank you for this opportunity, Dr. Andy. He's my mentor right from the days when I started in Akwa Ibom, and also happy to have the first person to his arms, Dr. I started with Heartland Alliance, and everything I learned started from the foundation that Heartland Alliance laid. Faster than controlling this slide, I'll also be using my laptop. Okay, so next slide. I'm just going to give a background of. I know not everybody is very conversant with harm reduction and some of the issues around harm reduction and people who use drugs, especially in Nigeria. So I'm going to start with a background. Next slide for the benefits of those people. So people who use drugs are disproportionately impacted by HIV compared to the general population. We know that is the reason why they are included as key populations HIV intervention. Why is that so? Is because they have a myriad of issues from legal, their drug use and sexual practices and social issues around them that leads to this higher vulnerability for HIV. We also know that criminalization of drugs and possession of drugs for personal use has also contributed to the whole to increasing this vulnerability and has marginalized people and introduced other layers like stigma, discrimination, exclusion, and a host of other issues that prevents people who use and inject drugs from accessing HIV prevention and treatment services. We also know that drug injecting practices mainly needle sharing, which is very common the world over, and sex for drugs, women who use drugs, has contributed also to that vulnerability. There are also social issues such as stigma, discrimination, exclusion, poverty, gender, and social attitudes toward drugs, which exacerbates this issue. And from data that we have available online and by the WHO and other institutions, we know that the people who use drugs are 25 times more likely to have HIV than the general population. We know that between 10 to 30% of people who inject drugs are women, but women who inject drugs are more likely to be living with HIV than them. It's one of the things in Nigeria in global. So, looking at the most recent data that we have that has been published in 2021, 10% of all new infections in sub-Saharan Africa was among people who inject drugs. And it's not far from what we have from IBSS, which puts it at 10.9% in Nigeria for people who inject drugs. Okay, so apart from looking at HIV, we also have to consider other occurring issues. That's people who have one of them, and the access to prevention and treatment for comorbidities. This is one of the issues which, though might not be directly related to HIV, but which we find in the community of people who use drugs. We also have a drug use dependence and access to evidence-based drug treatment services as one of the things, which is not directly related to HIV, but which will also allow for better outcomes for people who use drugs and also enhance HIV prevention if considered. We also have other sexual reproductive health and rights services for women who use drugs and access to information and availability of harm reduction services. Sometimes the services are available, but the people who use drugs or people who use and inject drugs do not have access to this information, so they can access these services. And then we have some, which is violations and abuse of the rights of people who use drugs by state and non-state actors. State actors like law enforcement, non-state actors like what happened recently in the Igbo states, where people who, when we had the methamphetamine epidemic, people were beaten up, brutalized, and dehumanized because they were using methamphetamine called gurumi. Those are things that also, exacerbate, the vulnerability of people who use drugs, HIV. And then, last but not the least, and one of the very important is social security, requisite skills and opportunity for income generation and meaningful livelihood. Of course, person when no get work, now they will use that. Abi? Right. And a hungry man is an angry man, right? So we understand all of this. We go to next slide. I'm just going to put us through an introduction for people who may not be very versed what harm reduction is. I'm not going to go deep, so I'll just read through. You can always get this information online if you want to understand harm reduction deeper. So what harm reduction is interventions and policies used to decrease negative consequences of recreational drug use and sexual activity without requiring abstinence, recognizing that those unable or unwilling to stop can still make positive change to protect themselves and others. So what it means is that it's like this what somebody told me about what she does with her husband. Whenever the husband is traveling, she says she puts condom in his bag because she understands that her husband is not ready. And so in case the husband wants to cheat, the husband should understand that he should use a condom. That is what harm reduction is. We know there are people who are not willing to stop drug use or able to stop drug use at the point where you and we present them with information with all the risks. You can scare them as much as you want. That if they take one drag of cannabis, they are going to get mad. You can do all of that as you want. Harm reduction is that thing that helps them to make positive changes and reduce the harms and all that. So basically, the harm reduction prevention basically has switch program has started before once. The needle and the switch program, some call it the syringe exchange program, but we are trying not to use exchange for this because well, needle and syringe program now does not require that you return the needles that you were given before you get the new one. So needle and syringe program is basically to give clean needles, clean and sterile needles. You give it to the person who injects drugs so that the person reduces the likelihood of sharing contaminated needles or used needles with their peers. We also have the opioid therapy and other drug dependence as part of harm reduction intervention. And then the very important one, which Dr. Salahuddin is helping us to the community, overdose prevention. We say community naloxone because we can have naloxone but not have it where it is needed. If naloxone is in the hospital and people are overdosing in the community, before you get to the hospital to get the naloxone to come to the community, that person is already. So naloxone is for the management of fatal overdose. And then we have the rest, which is general to most of the general populations like HIV counseling and testing, antiretroviral therapy, which is treatment as prevention and treatment of STI, conduct distribution program for people who use drugs and their sexual partners, vaccination, diagnosis, and treatment of viral hepatitis, prevention, diagnosis, and treatment of tuberculosis. You notice that there's the last point there, social protection and integration. This is an enabler, and it's one of the things we are debating to be included in the Nigerian harm reduction program. Because without social protection and economic integration of people who use drugs, we will keep doing harm reduction, giving needles and syringe or doing opioid substitution for the rest of their lives. There needs to be something to take over. All right, next slide. After looking at all of this, since we're talking about how HIV prevention using harm reduction approaches in Nigeria, how do we make harm reduction fit for purpose? 9 interventions has been listed by WHO and has been recognized globally as a way of reducing the harms of drugs. Then how do we tell all that in country we need to fit into our own context, understanding the population we are intervening for, the socioeconomic situations around the population we are intervening for in Nigeria, like this for the benefit. So, for to make harm reduction fit for HIV prevention among people who use drugs in Nigeria, what we do from our work is that first of all, we need to have HIV prevention, information, education, and communication materials for persons using drugs other than through injecting routes to prevent risk of infection if injecting use. You get that? There are people who are already using drugs right now who are not injecting. And we understand that people do transit from smoking to injecting. So how do you make information available for these people who are currently smoking so that they do not even try to start injecting, which will increase their vulnerability? But if they ever do transit to injecting, that they have information from day one to protect themselves so that they are not infected. That is how to make it in Nigeria. We also have to decriminalize possession of small amounts of drugs and harm reduction commodities for personal use to allow for increased and unhampered peer outreach and increased uptake and retention of peers in harm reduction program. When we talk about decriminalization, there's always whole, dust rest. But let's imagine that I'm a peer worker and I have needles and syringes. I'm going out with needles and syringes and I'll go and give to my community members who are injecting drugs. And then as I'm going along the way, the police arrest me. Whether I have my ID card, whether I have my program approval, in fact, for all I care, you can even carry the project in printed form out there. The role of the police is to arrest you because the law on drugs says that you should not be in possession of drug use equipment. Needles and syringes is drug use equipment. So how do you energize and empower harm reduction programs when you are still criminalizing drug possession, small and drug use equipment? That is one of the things that we need to do to make harm reduction fit for purpose in Nigeria. Community engagement in design and implementation of harm reduction programs so as to take into context community preferences for harm reduction services. And this is one lesson we've learned recently um, in trying to implement a United hepatitis C portfolio. It's a research, and one of the things that the research requires we do is that we should seek community preferences for needles and syringes. When we got to Gombe State, we realized that what was common was a 2 meals and 5 meals syringe, and the corresponding blue and green big needles. And we felt, oh, if the community are using this, it means this is their preference. And so when the Global Fund asked us what kind of needles we wanted to procure, fine, we knew that there needed to be a transition to loading space, smaller syringes and smaller needles to reduce vein damage. And so we said, oh, if you have an alternative, the alternative would be 2 meals and 5 meals. But on the hepatitis C project, we had the opportunity to have a focus group discussion with community members, and we realized that everything we knew or we thought we knew about what the preferences of the community was wrong. And so the lesson learned here is that if we must implement harm reduction for community of people who use and inject drugs, the strategy, the materials, and the everything around it needs to actually be from them. It is that way that you can improve uptake, and it is that way that you can increase retention of these persons in your harm reduction program. The next one is the community availability of naloxone for prevention of overdose death, which is something we all know. Of course, if our goal is to make sure that, if our goal is that we want to see people not use drugs any longer, we have to first of all keep them alive long enough for them to make that decision. So community naloxone is a sine qua non. Increased scale of, sorry, increased scale of social media, sorry, okay, increased scale of harm reduction services for people who use and inject drugs like needle and syringe program and medication assisted treatment therapy. Medication assisted treatment is the name Nigeria has adopted for opioid substitution. So it's to allow, I think Ogas Alauddin will say more about it. But if we look at it, and in Gombe State, we have 16,000 people who inject drugs. And in the GC6, our target to reach injecting drug users of 1,530. What percentage have we reached? Are we doing enough? Are we actually going to be able to achieve the state targets that stage? So there needs to be increased care. And it shouldn't just be about donor funding alone. It should also include government making a commitment to fund harm reduction services. Availability of women-friendly and centered harm reduction services, improved uptake of harm reduction services. And this is something that we need to be very, very particular about. That was during when we had the pilot needle and syringe program. And so in-house, we sat down and started asking us, let's look at how many people have we tested? Let's look at how many people are positive. Let's look at their sexes, male and female, broadly, not gender, right? Broadly. And then we realized that what happened was that we were only able, of the people that we reached with HIV testing, only 14% of them were women. Only 14% were women. But when we looked at the positivity rate, we found out that 65% of the positive persons were women, 15% for testing, and 65% for positivity. It was from that that we started looking for funding to support women who inject drugs to have their own program on their own. And then Youth Healthcare came up with the support, which is one of the projects that a lot of other organizations are benefited from. But it was from the data that we got from Gombe State and advocated. And so we need to increase this across all projects. And when we noticed that, we said in the district we were going to it. As we speak right now, we are struggling to get to 27%. We are 26% because women, because of the social issues around women, because of the, especially in the north, cultural issues, it's difficult for women to come out to access services. And they're the ones who are the most vulnerable to HIV infection. So we need to look at designing programs in a way that it allows for better reach to women in particular. Right. Next, increase scale and emphasis on integration of evidence-based drug-dependent treatment services at settings that allow for access of drug users to the service. One of the things we have in our programming is that, okay, let me put it this way. We understand that why people are vulnerable to HIV is because of their drug use. And we understand if people do not use drugs, their vulnerability will reduce, right? And so we are doing harm reduction services, but we are not looking at integrating this drug treatment. When I say drug treatment, it's like what people usually refer to as rehabilitation of people who use drugs. So we call it evidence-based drug treatment. Now, the thing is that we have this rehabilitation of evidence-based drug treatment services in another facility, most likely in a tertiary. And so this person gets HIV testing here, gets needle and syringe program and services. And we expect the person to go to the Federal Neuropsychiatric Hospital to get drug treatment services. It won't work. First, the person is already stigmatizing himself. Secondly, most of the people at the facility might not understand issues around people who do. So how are you going to get them? How do you stop them? Or do we keep giving them needles and syringes? Do we keep spending money to buy needles and syringes and methadone to give to people without actually looking at how to help them to reduce their vulnerability by lifestyle change? And if we want to do that, how do we integrate this? We have to integrate it into the same system where they are comfortable to get service. And it is one of the things that we are trying to do in the state, even though we are using a model in the state specialist hospital to take advantage of their trained doctors. So we need to look at it from that angle. Reduce their vulnerability by reducing their risk through reducing drug use. All right. So we need to also have availability of complementary support services to promote social integration, like income/skills generating support for people in harm reduction programs. Because if they have something as an alternative, it makes it say, okay, how do I switch my time between my drug use and what I have as my job? Most of the people who who are not dependent on use drug recreationally without actually being dependent on it because they have some other things. So you see this guy who goes to work in the morning, in the evening, he comes back, he sits at the garden and he's smoking his marijuana or he's injecting his drugs and then he goes home to the next day he's off to work again. But the other guy that has nothing to do, finish injecting and sit at the hotspot and they select the person to keep injecting because they have nothing. So we need to look at that. We also need to look at the integration of other services for people who use drugs to improve the reduction service outcomes. So you're giving me HIV services, and then I also know services. I'm pregnant. I have not registered for my antenatal. You know, I don't know how I will go because I don't have a job. I don't have anybody supporting me. I've been stigmatized, excluded. How does it come out? How do we get right outcomes for the services? How do we actually say that we made impact by giving harm reduction services if we cannot cover for these other services? And includes a lot: cervical cancer screening, surgery, family planning, because so I can't afford food, and I don't know about family planning, and I'm using drugs, and I get pregnant. It increases my problem because I now have to think of a child, and I have to eat for. So I keep putting myself in that puts me in a place where I am more vulnerable to, having cancer or and then contract just because I want to feed. So we need to look at that. We need to look at the increased scale of social media information for the young people and for people now who are now social media savvy, who are living with social media. We need to see how to make use of those spaces to provide information, not just information for the people who are using, but for the people who may use drugs, but also information for the parents who have children who use drugs, who do not know how to handle it, and who want to drive them out of their houses. Because driving them out of their houses will make the case worse. We have to use the social media space to be able to, help with all of it. And then we should also look at the increased scale of HIV testing and treatment for the community of people who use drugs. Thank you very much.
Thank you so much, Media Man, for your very wonderful presentation. Please, another round of applause for you. He took his time to take us through the entire process from understanding of people who use drugs. Particularly associated with that because the population of people who get drugs is much smaller than drugs. From that viewpoint, when we look at all of the treatment processes, both the clinical program, which we're piloting or is being piloted and being implemented now, and also even the medications of I think we'll see and hear more to the next speaker will be introduced by my co-chair, Grace Dongo. So we'll also take over the chairmanship of this session as I rush off to the airport.
That's
Alright, so next speaker we have is Olawale, Chairman National. So, actually, I saw launch. So that launch is taking. So yeah, however, this is a responsibility. So thank you very much once again for this opportunity. But thank you for managing to pronounce my name. So thank you. So I'm Dr. Jima Olawale Salawudeen. I'm Director of Food Services and also Chairman National Technical Working Group for Drug and Addiction in the country. So thank you so much. I've listened to the Chief Alegi, who happens to be one of the major stakeholders of this harm reduction so far. Looking at the title of today's presentation, Advancing HIV Prevention Strategy who inject drugs, a focus on harm reduction in Nigeria. First of all, I want us to, what is really that harm reduction? Before we drug harm reduction, how do we prevent the harm that is happening to our fellow Nigerians as a result of drug use? That's what harm reduction is all about. So any policies, any programs, any practices that can help to reduce harm done to a fellow human being, especially Nigerians, as a result of drug use, is what we call drug harm reduction. Now, this harm reduction program is focused more on those who inject drugs. Today, the population of Nigeria that are drug as of 2018 is 14.3 million. This is UNODC. I also participated. And of this figure, fortunately 80,000 are on injection. Now we are here fighting HIV, which we know is blood-borne infection. And statistically, it is observed that among the general population, the efforts on HIV is 2 years before we were struck, the prevalence among people who get drug was 3.4. But today, means that injection use is having more to do with HIV. Same with hepatitis. Among the community of the number what is what are the communities of WHO did a lot of work. And before I even say this, I want to tell them because their effort is what is really what we have today. From WHO to the Alliance to Spice and so on and so forth. Because having observed this problem, and having seen that efforts is giving positive results as a result of activities of HIV, but it's not yielding anything as a drug community of drug users. So they start together and approach drugs. Unfortunately, they were told that they were going to arrest them. So they now thought it wise. And I was fortunate that my own minister sat with the drug reduction, which has to do with the prevention and control of drug. So when the approach was, let us begin to try. Why is it so sensitive that the other sister just say they are going to be arrested? Let us look at the drugs that reduce themselves. Culturally, religiously, it is something Nigeria today. Second, we also say opioid substitution therapy, meaning that we will be taking one away from them, we will be giving them another one. If it is not well done, Nigerians will say government or people the third one, community distribution of naloxone. Community distribution very important. Why is it important? If you recall, some years ago, armed robbers were arrested in Lagos. And now are they arrested at the scene of robbery? One of them slept off. You had the went to rob. So police is not done catch you. If you do that, don't catch you. You arrested the person, took the person to your state. Maybe the person will go to work. They did not mean that people that this guy must have injected himself before robbery and infected the happens to the state. So the question is, in the course of the case, will not be there. Most of these things are happening at corners. And another where is happening. Why? Because the people inject drugs, according to my so if they give themselves an overdose, and the side effect of that overdose is sudden cessation of breathing. And once that thing happens, once the breathing stops and blood will not flow into the brain, the person will go unconscious. If that thing lasts for 5 minutes, you can't bring the person back to life. So there's an injection that once it happens, give that injection, less than because the people are blocked where the drugs hold it. So if you say it should be facility, that drugs be in the facility. Before you take the person from scene of incident to where the is gone. So that's why the WHO says community distribution of naloxone, meaning we should give this to the people who are in this drug. So that if they mistakenly take overdose, and unfortunately overdose is this. Along the line of you try to withdraw. But because he went to try to tell some friends, said, no, it's not to give up. He will have forgotten that the system has gotten used to that 10 milligram. Now that it's stopped, the dose is really going, the body is only treating me. He will still have the 10 milligram. And so, WHO says, distribution of naloxone. Now, number 4 is there's so many, there are about 10 actually, but this middle syringe, opioid substitution therapy, and this are the key. That others are what they are issue of chronic disease, HIV, issue of TB, also are all going. Nobody is challenging that, but these 3. I know this is however, that is not I will put up who are that will give back to National Technical Working Group in 2019, which is support of the partners locally and internationally. Kudos to all of them, because in the whole world, when we are really presenting, that government is leading. We have to feel some countries where they are doing the best practices and to develop our own policy. But along the line, we cannot continue that we don't have experience. So the technical working group agree that international partners will be developed in 4-5 states. We did it in Abia, in FCT to Nasarawa. The issue of let us say hepatitis was initially possible, but we realized that to get all these kits based on the funding is something different. Okay, let us whether the community will even accept this concept, this idea that we are looking for. And the pilot studies now, in terms of the needle, it is not just ordinary needle, because the consequence of drug is one. The act of injection is because most of when the injection is up, use all the hands. At times the blood will clot. The hand will use it. At times they start using the leg. Once the blood cannot go easily again, and unfortunately, a colleague is also of mine who is also involving in drugs. In the course of injecting the leg, infected 7 liters of pus was drained down his heart. Just for the excuse. So the trauma of the injection. So in view of this, the kind of needle which is like a painless so the beauty of this accepted and over 2 million civilians are not. In fact, they are still young for more. And to God be the glory, and other international partners, we are scaling up. They are also. But the issue is, how are they able to accept this? Realizing that there's a law that says that if you have syringe and needle, or you have injection power with you, you are not a doctor, you are not a doctor, you will problem. The only way to navigate this is clear approval. And then the issue of state entry. What do you mean by that? We know how sensitive this issue is. Should the media just pick up this in the wrong way, we are in trouble. So, with the support of partners, we did what we call media engagement. Unfortunately, they want to that area. Because whether we like it or not, either it's family, somebody said that in our family, you should say wrong. And the best to handle it. After that, the state, how will they understand the that to the commissioner. We expect after we are coming to the state. Please prepare the state. What is that preparation? Governor, the permanent secretary, the commissioner here, the major stakeholders, the community, religious leaders, community leaders, all of them, they prepare the security agencies, police, SSL, we invited all of them. And after explaining the concept, and they accepted it, we now transform them to implementations who are actually going to supervise the act of distributing this to the community. And I can tell you today, I'm happy with all of you. And so forth. The community accepted and the world act to continue. A lot of studies are ongoing. As a, at least acceptability is there. Now moving the step further to assess the impact of what we are really doing. But it's another fundamental question. If you screen me before you start giving syringe and needle, for hepatitis C, for example, and I'm positive, what next? If you are negative, what next? If I'm positive, are you going to leave me? Child, I mean, to mother, and for hepatitis B, if you are being screened and you are negative, you are working toward being vaccinated. Now, the systematic way about how you is this: you are why? Because if you stop that from they can some of the cases that come from hospitals, federal department, there was a case that somebody actually on the toilet, what they call it, toilet seat, because so when you are tired of packing what you have to transfer the person to the toilet, whatever, when they do not what common grass said. That is why to stop taking the drug. But the survey that we did shows that about 40 to 50% of the patients themselves say they are tired. They do not want to take this drug again. So the only help we can do for injection is win them over from sharing with the other something that community they call one love. If I'm the only one that's having injection, I will do it and I have others with me, inject myself, withdraw the blood, to share it. That is what. But now they see the sense in having syringe and needle at their disposal, and nobody is running about after that. This is what sense means. Now, by the time they accept and not sharing, we know we are moving toward reducing HIV. Which is what we call opioid substitution therapy. But we know as Nigerians, when you still work grammar, you can interpret it in so many ways. that institution take one, give it. So we have to now change the grammar to medically assisted treatment. Very soft to somebody here that it is medically assisted treatment and not opioid substitution therapy. Then we use methadone and we use buprenorphine. What does this one mean? The injection users need to be high, but we do not want them to continue to inject. So we will now win them over for the injecting to this methadone. And by the time they start taking this methadone, the dangerous ones go away. But by the time we now ask them to start methadone, all these withdrawals are there. That is the essence. And at the same time, they are injecting, we ensure they have naloxone at their disposal in case of overdose. As I'm talking to you, we are getting marvelous results. Needle syringe is ongoing, naloxone is accompanying it, but this other one I mentioned, we are still, because that drug itself, according to what we learned from our partners, is not a drug, but when we are carrying it from one center to another center, there is project at the back, police at the back, because they were laid on the road. So we are doing the story is also very important. Fortunately, that was also for another purpose. In order to gather more experience, what we have in the story, the Ministry of Health, my principal, Minister Paul, you are so gracious that since you are doing this, let this service be one of the institutions to start the pilot. And we are doing that. And we know that take this. The damages will be reversing. When you are able to do it, we are getting positive of that. But we want to use it generally. Thank our FHI3 to LHVN, so we are placed order to start piloting in all states where we are even done. I can tell you that opioid use is a serious matter. Opioid use is something that can suddenly take life. But if we can manage harm reduction successfully, we will be there. I mentioned 10 components for harm reduction, but I mentioned we had an extra one that is missing to us in Nigeria. Because when you get outside the best for adaptive psychosocial integration and economic empowerment. Remember that when Oga Anedu was presenting the other time, he mentioned that a high war hand is always the devil's worship. If you are winning drug users out of the drug use, find out what to do. Way to empower them and you are able to win them, they will be responsible members of society. But remember one thing, if you when you are alive and you are thinking of winning them, otherwise you can't win the dead body over time. That's why what into issue of harm reduction to win them over so that gradually people will be able to get out of these drug use. This is how we are going in Nigeria, and by that will be researching into the outcome or impact of what we are doing. That is all. Very much.
Thank you so much. Let me use your first name. Jimo and Jimbo are almost the same. All right, thank you so much, sir. I just want to know whether we have an active participant. What is one law? What is the 11th strategy that added one? This place is active. So put your hands together. All right, thank you. I just want to know that. So we'll just go straight to the question. I want to know the journey. I'm from the Genesis now, we understand the but I know that even when I issue of gender and harm reduction coming strongly. So I need to take 10 minutes, so I'm going to take 5 questions. So 5 questions, 1 minute each, and then 5 minutes. Can we go that way? All right, just take one. If you have a question, don't raise up your hand. So, three, three people. That's it. All right. I think I asked you, so it's almost fine. I want to start with you, please. You just introduce yourself and take it. All right. The second question.
Thank you very much. My question regarding the impact of sacrificial support and economic empowerment. And to the first to find out these palliatives across the nation and across the city. We have to deliberate on educational efforts to make provision for our children that are having these we have to give them and sustain them. And we also increase our advocacy to the development partners. Particularly integrate and make provision, budget provision for rehabilitation because we have various programs. And that's why we have produced mental health and psychiatric support. They are not integrated to make budget to support and rehabilitate them. Because like I did say, advocacy will always have some other things that need to act on the coming up. Thank you.
The next person, thank you.
Thank you so much, my brother Lady, for that presentation. And of course, our God and many
but they did not know the way forward. So unless you go through that, through so many routes to talk to them, look, let us talk. But then, from the Ministry of Health angle, we also came into another corner. Mental Health Act mentioned the issue of the criminalization of drug use, that it is a mental health problem. So please, let's have a copy of that Mental Health Act, which was passed, I think, about 2 years ago. So, yes, that person is being mentioned there. But the original owner of the document that is enforcing the law, NDLEA, they will still tell you, yeah, but they are cooperating seriously as that's true. In fact, right now, they are even championing harm reduction now, taking it away from the Ministry of Health, who are the original owner of health aspect of drug use. They themselves are really carrying it. So we are together. IG has presence in all what we do. SSS, even the military, they are all participating in what we do. As long as we identify that this person, it's just we are having problem now is what quantity will qualify you to be a dealer. That is the area we want the threshold. But NDLA has not come out with that. Because the fact that I want to take Nino does not mean me a criminal because you decide to take it. It is his own choice. It's not me, the act of taking. It's his own choice. But when you now start selling that you have enter criminal level, but the level of awareness NDLA now, they are not as harsh as before. Talk to the National Assembly that they should understand that drug users are not.
All right, thank you very much. The questions except to just respond to Doctor. So, Doctor, I think it's a system. That will depend on another PhD. To do that. If the local government actually say you want to fund drug harm reduction, it will be a piece of cake. But what we need to ask is whether that political package of having an evaluation report of the full package of harm reduction in particular state. Hopefully, services, and that is going to start by January 2020. Including the mass services will start this year, and so viral hepatitis, and that's the whole idea about having all of that, so that we understand if this is effective in the context. And once we have that report, we'll share it nationally with everyone. And then, Madam Grace, yes, we are doing encouraging women to first of all organize. The project we're implementing with the health cohorts of 30 women-led cohorts. Fortunately, only one has come. We try to encourage them. They had like 450 with everything, even when we did not have money to help them to organize. So that at least having one is something. Maybe if that one will go ahead with the way we are going with them, we provided women affairs in the state skills training, fortunately give helping which will encompass a whole lot of women like manicure, pedicure, and all of these make if we can succeed in that way, maybe it will save us for it to be brought and to formalize. And hopefully by next week, we should be inaugurating that work. Thank you.
Thank you so much. Please let's appreciate the speakers. I have learned section. I think I'm ready for without minutes here. I want to thank everyone that came, both from online and physical. I also want to thank the organization I represent, excellence community. I really appreciate it. Thank you so much. I pray that you go back, have a restful evening. Hand over what was handed over to me. Who do we hand over to me? Who will collect from me? Because the chair is hot and I need. Yes. I am here. Thank you so much. I see my chief of party, sir. I recognize you. I don't want to get query when I come back from here. This session is officially closed.
Thank you so much, AQs. Thank you so much, MNI. Can you put your hand session, enlightening session? Can we going to be taken by IHBN? Can you please settle down? We are going to be inviting the chairs and the co-chairs of this session. Can we please settle down? I would like to introduce the next session, which is going to be by IHBN, the Institute of Human Nigeria, which has been programming for the past since 2004, and prevention and treatment, TB, HIV, malaria. In this session, we are going to be looking at the experience of improving HIV prevention performance through of the nasal and syringe program people who inject drugs in River State. IGN of the NAHI grant, which is a government grant through FHI 360 to implement the syringe program in River State. It's a follow-up session, it's like a follow-up session today. So I want you to put your hands together as I invite the chair of this team. So can you put your hands together? He's going to take over from me. Yes, we have chair who will be introducing all the other guests that will be here. Put your hands together.
Good evening. So I'll be inviting the co-chair of this session, Mr. Sam Burapa. Please come on. Put your hands together for him. So I'll be introducing the panelists for this session in no particular order. So I'll be inviting someone who is coming from the field with experience. Then he's going to be talking about this panel. Please help me to invite to the platform Mr. Talent Anyason. Mr. Talent works in River State and has a very strong experience working with me. Shewemi is not in the room. However, he has another completing section with that session. So I'll invite. So in no particular order, like I said, Mr. Silas is technical advisor on and research coordinator for the self-test and has over 3 decades of it. So next person on this panel is Dr. Ufoma Edewo. Dr. Ufoma Edewo is a public health physician and deputy director of the River State Ministry of Health. She's also currently the program manager of State Aid and Health. So, so, so we are good, right? Dr. Michael, yeah. Panelist.
In this panel, we have harm reduction. Welcome, Dr. Kingsley Michael. So keep the ball rolling. Honor in our midst the prevention, care, and treatment in the someone who has a very programming
especially also in the trust clinic, us as we make welcome more to give us opening.
Thank you so much, Sam. I'll just give an outline. We will be taking goodwill message. Thereafter, we have a presentation of FL1 answer from the panel, and then so like to come to that place is more convenient.
Good afternoon, everyone. Welcome to for taking us time to be our panelists. Thank you. Program. We've had a lot of issues and reduction that to achieve country, there is no way we can afford to specific behind. We need to find what spots are, we need to find where people where still on and all that's there. We know that people who inject are unfortunately affected by HIV. We also have the fact that prevalence of HIV is almost 2 times higher than the overall population. So it's very important that in now to parents to targeted to achieve some success in ensuring that we put up the HIV the population. We are very important that we involve the plan and the implementation. And so from the previous experience where we cover which is global implementation and the program, we hear all that shortly we also part of the program where I remember some years back, somewhere in US, the state of the yeah, being hospital. And they tried tracing where the spread of the was coming from and also bring down to people who reject the that was one of the communities where the people was not accepted. When the government saw that, he people and the community here. So we cannot downplay the importance of the transmission spread of HIV. And we remember that emphasize that's the importance to want to look to therefore, we keep the River State Institute to go ahead and the implementation of grant.
Good afternoon, everyone.
Good afternoon.
All right. In the presentation, on the improved HIV prevention performance who inject drugs in Rivers State. Okay, so this will be my outline. Talk about the objectives, the strategies that were used, the outcomes. Globally, the people who inject drugs are and viral hepatitis B and C. In addition, currently around 11.8 or 1.4 billion of these people are actually living with HIV. Drug use accounts for approximately percent of people who live with HIV among people who inject drugs is currently at 11.9% and is amongst the female period as compared. According to the National Drug Use Survey, 4% of the general population, and this gives 6%. So we can say that we have the global prevalence of people who inject drugs. That are strictly used increases the vulnerability of people who inject drugs to HIV, sexually transmitted infections, and other viruses. Now, this is a background of how the project was implemented in Rivers State. That the National Aligned HIV/AIDS Initiative has the grant that was funded by Global Fund. IGN collaborated with Government of Nigeria stakeholders, Health, NACA, SACA, the Drug and Harm Reduction Network, security agencies, National Law Enforcement Agency, security. This was in order to support the state. That's a map of River State showcasing LGAs. We have 2 projects in the state, and that's the right. The project was implemented by Global Initiative, while the blue is Diadem Consult that programmed in those environments. What were our objectives? Create access to HIV and hepatitis B and C, to promote health through access to risks of infection associated with needle sharing, to provide education related harm, and also facilitate access to community by providing waste management process of these used needles. What strategy was mobilization and community engagement? We started with the mapping of the state level stakeholders, and this was followed by, and these meetings, the State Ministry of Health, we had Ministry of Health, and the National Drug Law Enforcement Agency with community and the site of things with this field support engagement with bank owners and also into those areas where we were going to be implementing this project, and then community facilitators and social mobilizers. So map services that were provided include waste management agencies, the service agencies, health facilities that had incinerators. We also looked at legal services and other relevant government bodies that we felt were going to lead to successful implementation of intervention in the state. About our strategy for the engagement of civils and volunteers, and these volunteers include the community facilitators that were engaged with civils, and then we also had the outreach workers, social mobilizers. The social mobilizers were actually responsible mainly for advocacy and engagement with the respective people groups, provide an enabling environment, and pave the way for interventions that we had. The facilitators were responsible for directly production intervention. We also had training and retraining and capacity building sessions. Training was conducted using the NSP model. Human rights also had motivational interview, drug overdose management, assessment. The photograph you can see there, top one was at the initial point of time with continuous engagement with these relevant stakeholders. So, also introduced two prevention package for the PWIT. So minimum prevention package intervention is defined different classes of prevention activities vis-a-vis create on multiple levels and also and it was aimed to respond to the specific needs of transmission and also to make efficient use of resources and engagement of the affected community. These drivers of the epidemic. The needle syringe program was for the people who inject drugs. The minimum HIV interventions that we had for the people who inject drugs include the needle syringe program. We also had information community members, social media platforms for drugs web services, and there was the condom programs for these people and their sex partner. We had screening and welfare treatment of viral had CI screening and in cases where the STI were detected. It was also the prevention, diagnosis, and treatment of tuberculosis. We also provided mental health and psychosocial support services, also sexual, also made access for intimate partner violence service, and also we linked them to legal service centers where they could access legal service if needed. Next. Next. Okay, now what was the outcome? At the end of this, we had, with support from the Institute of Human Biology, we had over 63 community facilitators that were trained. We also had programs on the needle syringe program. ISBN also supported two period implementing CBOs, that is Global Initiative for Health and Rights and Diadem Council. They were engaged to train the community facilitators who also facilitate the needle syringe program in the state. ISBN is a recipient in this new for that the new Global Program G7 has support to continue this project in 12 states. And the lessons that were learned will be utilized in this outcomes for this new phase of the program. Next, please. All right. So, what was the effect of our community engagement? Like I said earlier on, we engaged different stakeholders. We had the religious leaders, both Christian, we also had the Muslim community. had community leaders from all the local government representatives, from the women group, the community, community development committee at the local government level. We had representatives from all the LGs, members of our technical work while this project was being implemented. So we had religious community leaders, religious community work, community leaders were there. We also had faith-based organizations that were there. Other relevant stakeholders that security agencies like I mentioned earlier on, that's Directorate of State Security, the police are very well involved as part of this project. Now, what was the effect of this stakeholder engagement on key population prevention performance? This graph is a presentation of the project from April 2022 to December. Sorry, please, I'm still speaking on. Go back. Sorry? Oh, my system froze. I can't even move forward. Okay, thank you. So we can see that by the time we started this program, there was an increase in quite a significant improvement in the number of population that reached interventions. We can see that the peak started gradually increasing, and it peaked somewhere between January to March. There was a decline, and that decline was as a result of delay in supply of immediately commodity queries. There was nice contribution of the with total key population that were reached with intervention services. Next, please. Next, please. Okay, so what were the lessons that we learned? The state-led community entry was instrumental to improve the outcome of the needle syringe program in the state, and the implementation was both national and state-led engagement. There were reports of high police arrests and poor engagement by the community facilitators. The mapping of the stakeholders was inaugurated at the joint meeting in August 2023, and the inclusion I mentioned earlier of religious leaders, youth leaders, representing the National Government Agency, police, security, the Directorate of State Security, their medical team was very, very involved. They never missed any of our stakeholders, and whenever we needed their support, both the DSS and the police were always ready, and same with the FDA drug person in the agency. They were very, very supportive of our implementation. Same with the traditional rulers. They were part of our stakeholders meetings every quarter. And even when we go to the community, for the community, whenever the community facilitators have to go in, because they had access, they had their contact, we reach out to them, both the community leaders and traditional leaders in the community, and they sensitize them on why these people are coming into their community with these interventions. So this improve awareness and ownership of program. The needle retrieval, sorry. No. Okay. So my slide is blocked. The inclusion of the religious leaders, like I said earlier, the women representatives, police, security agencies, and traditional rulers improved awareness and ongoing advocacy and social community. This led to recruitment of over 9,000 PWIGs on the needle syringe program. We also had our waste management disposal process, and the success rate retrieval of used needle and syringe was achieved through this approach where people that were engaged on needle syringe program were trained on waste management strategies. All right, what are our recommendations? One major recommendation is continuous advocacy. This should be paid to the local government chairman, because at the initial stage, most of them had no idea. Because they see these drug users as bad people in the community, but by the time we're educated, they understand that we actually need our support to to be able to reduce the risks associated with injection drug use. They were more supportive of they had a better understanding, and they were very much supportive of the implementation of the project. So we recommend that there should be continuous support to the local government chairman, the chief, religious leaders, and the various security personnel. We should also have a statement that will give us the opportunity to continue to create awareness and monitor joint stakeholders. This we can achieve by training the religious leaders to change their judgmental mindset against the people who inject drugs and the entire needle syringe program. Could also have the involvement of gatekeepers such as the bank owners in the decision-making process, and there should be education and awareness to people who inject drugs of their fundamental human rights. And we should have improved sensitization of social drug users through youth groups, and then we should social media platforms and also radio programs. There should be continuous production of IEC materials on the comprehensive package of the needle syringe program, and we should also be able to develop a referral and contact directory for the key stakeholders. Next, please. What are our next steps? Community sensitization and awareness creation on the needle syringe program, and that's the chief, the various women in our community, achievements that we have recorded so far, and like be able to with this needle syringe program service provision through integrated service delivery, and we needle syringe program and harm reduction of facility for the methadone medication assistant in the University of Port Harcourt Teaching Hospital. To acknowledge and express my heart for creating the enabling environment for harm reduction program, National AIDS and STI Control Program, National Agency for Drug and Demand Reduction in the ministry, government and people state for adopting the harm reduction program at the subnational level. Organizations are in line for our appreciation, which are the Global Fund, DOD, and CDC. Tremendous technical of implementing the needle syringe program in the state under the NAI project, to whom we are eternally grateful for delivering in style expectations from organizations and sub-recipients with whom we must actualize a better future for the community of people in the organizers of this program, for giving us a platform to express our voice. Thank
Thank you so much, Dr. So here in the panel, and we have some who inject drugs. My question will go to the four different presented here. First, I'll start with the leader from the Peewee community. I'd like to find out how inclusive we are, the conception stage of this being part of it.
Good evening, everybody. I would like to share my experience concerning
can hear you. Can you put on your mic?
Can you hear me?
No, sorry.
Can you hear me now?
Yes.
Okay. So, first of all, let me just why they are this people reject God, their nuisance, their arrogance, their bad boys, their just be natural. And that's something that is already in fact, before now, the Jewish community has been lost in terms of stigmatization and also in our lifetime. There's a lot of because of the violence and in the past. So, if you go down to our community, you see that in terms of medical aspect, taking our healthcare, what is it about those and how we do our drug? We get that the sharing, forgetting about that HIV is associated from sharing of just share because of the aggressive in our society. We share in terms of the overdose. We don't care. Anybody who is other of us person as a person, whatever the person that's the pressure we have. Before I project. That started from here, we have quarantines. So before now, before this implementation is not taking just process of what is individuals who want to get whatever happens to the next person, we take it by this. That's how it has been. If you have another, I think another one might be that we beat you. I don't get the amount of sure that but for the help of there was a very huge change because the package was not just for going to sharing. It became of sensitization as and also sharing and so on and so forth. There are the attitude of the youth in Rivers asking for news, nobody wants to. That's why I want a lot of post. Okay, nobody cares about those things. So that there's change that now we are very happy that we are getting.
Thank you, Mr. Collins. So I think for Kiwi, I think it's 2010 was 3.4%. Because it seems like we have not been given a comprehensive Kiwi. That number and of course, there is a study I was just completing as a initiative that shows that ITC at 7.2%. My question is, do you think just like we had of the Devor's presentation, do you think it's and are we will probably start seeing a decline in the coming years? Because if you think about how this rich program is leading to change injecting material. So, what do you think national strategic framework in ending HIV?
Thank you very much. Good evening, ladies and gentlemen. Beautiful how you set the stage to the question. There is no how or if. The program correctly and judiciously implemented take us back discipline, right, to the test in accordance with the sustainability goals. Where we should engage the community, not do wake up and something less to this. Another space to investment in HIV response. Us here will remember that labor died from it back in the 90s. You know, where about 5%, a lot of people were coming down and dying. You would remember here that during the country, we were saying what can be done. And we were trying to have investment very well after 20 years of investments. 2018, the prevalence of HIV among population, is yourself and myself having this disaggregation, had reduced good when we respond to HIV. But the story is completely different when people use their drugs, as you just referenced. But a decade later, 2020, we had jumped and haven't done anything. And if we were not sitting in this hall, it's likely going to be 20%. Near Nigeria would likely have HIV. How is that going? It mixed epidemic, where you have the prevalence dropping among the general population in the key population, and it's only a matter of time for the truth back to you, beginning over the years. So this was the things that came not only from the local, but also globally that we have made in the HIV and vulnerabilities of injectors, and that's how we came about. Coming to us is to be part program medication assisted treatment. You are able to have incidents of it. Able to do like the WHO and UNODC recommend. You have that, and when you combine all of here, you just be able to achieve it by 2030. That's where we're
as an individual, what would be your advice or other saving gains and for people who have not even started on how best to approach the community to like that program, especially from their experience.
So, the next I want to say is this almost advice. You can't do anything. It's obvious that the community is the center where you can. Just building on the sand, foundation too. To start, you have to start and probably you have read where else. People should take note that to you will need all the stakeholders. If you look like the I mean nobody first the community members you have the which includes maybe you have a security paramedic buy-in also very important. We have the key is successful implementation of why we recruited together, discuss at various levels, advocacies really done before implementation. And it was evident that we need clear support because we got everybody who was and who is a stakeholder program. So, as a point that we map out these stakeholders, do your advocacies, do your engagement, ensure that you follow up and work in synergy so that you can, at the end of it, achieve your goal. And that's what we use. Why we are very happy that we were able to
but before then, I would like to ask the media people to get ready. So the last question to our distinguished presenter is just simple. How do you believe that implemented universities and what gives you that hope? Yes,
very much. Fighting on what Mr. Simon said, we are the most stakeholders experience, especially the sorry, each stakeholder is what else? We have had what is the president or vice our engagement opened up acceptance for that. What is the right and the rule of rights? So this is the past. We were invited to several occasions, especially but I was actually
Very strong stakeholders across the various stakeholders.
With that, the question from the audience. Please, take numbers. Take three questions. Number one. Any other person? Just take number two. Number three.
Thank you very much. My name is Dr. Galan. Let me appreciate the apart from the whenever you yeah, and there is high rate and rate. You have highlighted. You have a role in the engagement and stakeholders management. And the essence of community engagement and stakeholders is to reduce this. So what does the people engage the community and those stakeholders to reduce this concept? Secondly, I developed IGN. I'm studying nowadays, IGN is the following organization. The government
We take the second question and then response together for all the three questions.
Good evening, everyone. Good evening, everyone. So, my name is Dr. Naziga Francis, the project manager at National Agency for Control. I want to thank Dr. Relemo and Phoebe for I, Saka, was also part of this process in River School. So when you already put on what it is, like when so he that this program actually push to reduction and all the achievement with the agreement. Our concern is, so what is the way forward? So after all the and this is where we are. What's the rule? Gains be lost, all of these things will be reversed. Thank you.
Thank you very much.
Good afternoon, everyone. My name is Dr. Linda. Thank you very much, everyone. The panelists. So we talked about how expanding implementation to the G7 G7
actually looking forward to implement something that we were able but since then, edge started doing mistakes. So I'm just doing things that we implementing online system. Thank you very much.
Thank you so much. So we have question in so I think we have a question. The next one. So what's the record? Okay. So let's hear it.
My name is yes. Thank you very much. I'm also a university. Um, but then I have a question issue that is talking about and they have some partners. I didn't hear that support because that's the BNC is there just like in the Katsina State, or like an academic. So I don't know. When you have these BNC
Thank you so much. The next question from Dr. Linda, she asked if was taken up of the nasal syringe program. I would say that not just persons in the panel that answers and the government can also weigh into this. So for the question, insightful, that also applies to that.
Thank you very much. My colleague from another state. So at initial, from the beginning, we had a field on 8, but we noticed that I existed. Despite having a member of stakeholders, we were still having this high paid advocacy. Like big divisional advocacy. So when the job, he was expected to maybe the job was too much. So paid advocacy to the station. Position, not getting to that job. So that was one major position having issues with we also went to that. So all of the time we are the rates, so the initial instance of hybrid more house to engage this stakeholder. And like I also said, I was actually marked to yes, I need to know about that. Always available for all our meetings. Sometimes we won't need them to step in or I didn't think that level of security that I felt the police to cover it. Yes, we are not that direction. So that involvement. Eventually, they are even the vice chairman that came from Money. But there was a traditional ruler that came from one of the when you have opportunity to have meetings and they are very they find opportunities to have like all this project. So it was a continuous when any so that's ability. So as well then our improving and adjusting our mode of implementation. Thank you.
Thank you, everyone. So, back to what Dr. Edward just mentioned, in one of the PMCs, PMCs, the program management team, one of the things we actually discovered that we get entrance to most of the books during the work visits. There was this massive update by the police. So, subsequent visits, there was a traffic going to the knowledge of the deputy chairman or as part of the stakeholders committee. So that message that's the high level of achievements. Then, yeah. Okay, so the chairman has asked me to on the way forward, asked by the manager. I know that is a warning to the state. Whether that's a every transition kind of digital so the DC7, the DC7 is capacity actually kickstarted.
I just want to also say thank you for the significant Saka. Yeah. If you read the recent case estimate, the challenges that you are you need this type of program. It starts this way. Why and you given us assurance that you are going to support every means to ensure that this program comes to your place. I think there is a need for honesty. Thank God, Director of PCT is here. So she's a national staff and she will do better to take it further with management so that it's further with funders. Also, to depend on to do that. You may not be included in the GC7, but then other opportunities are there for other organizations that can do Thank you.
Okay, so on question number 4. Okay.
Thank you very much. So I'd like to speak to my longtime friend from Rivers State. It's nice to see you here. Kudos. So let's get an infection that results in damage of the liver after a important subtypes, if you like. For hepatitis B, we have treatment. Hepatitis C, we have treatment, we have cure. a lot of Nigerians are infected and they do not know because the fever doesn't get them until very last stage. And that so a lot of people die from it. That's involved in the chain to manage it. It's a bit long companies or governments to handle. So we've had instances where them, but we had co-analysis. At some point, they can was a big problem at that time. So it's sort of one, but that it had something. So we're testing them, and we're not complete. So that's who's particularly this question because I want us to do whatever we can to contribute in services for hepatitis. People need to get tested, people need to know their status, people need to prevent themselves from getting liver cirrhosis or liver cancer. That can vaccinate against at any age, and then all right, once you know your status. So we prefer working with everyone, and I cannot finish without mentioning about this. In his 4-point agenda, value chain is one of them. There's been talks about national had written a memo to him saying, out of stock, we're looking at calling in some of the pharmaceuticals from across the world. So if anything, give us active ingredient, and then we can locally package and assemble them. Thank you very much.
Thank you so much, panelists, and the audience. Discussion around the questions around the streets that we're going to be mentioned that GC7 is grant service as a global and is implemented together with other partners. And the states that will be implementing, yes, I feel you. I know that there were entry meetings and for us, NSP, the country where of the country and the okay, that we use to implement. The implementation is going to existing states. Okay. Of paper. We're going to have fund, we have four states in global fund. Also have so that is where we're implementing.
smoke, you go. No complain for here. No look your face. We are
We have some marijuana in my house that I would like to smoke with you. Yeah, yeah. It's this girl and I see her every day. Cause every day she a come around my way till one day me notice that she on the high grade. So me walk up to her and everybody I say, and Mr. Chan, I come from Japan. Anything you talk, I'm not gonna understand.
Oh, na, 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 na. Oh, baby, how would you like to be my queen? Let me ask you again, baby, would you like to be my queen? Let me be your king. I told you that I loved you the first time. You looked at me in the eyes and you smiled, oh yeah. I told you that I need you. How would you like to be with? How would you like to be the one who loves you? Yeah. How would my dreams? I'm asking you. I'll take you to the mountain. Face you wanna see my mind pop up. Hey. How would you like
I needed to sing the song because my brother never ever. I've been smoking ladies from so long. Let me know. I want to like smoke some. Yeah. I want to like smoke some. Oh, oh, oh.
You don't finish, I'm not more than go.
This is a whole production.
They said I'm not.
No go down very well. Senior man, we eat so this speak up more for your man. Senior man, we eat so stay well. So, no worry, you go. No worry. I can tell you about no worry. There's another man, right? I pick up that. No do that. Senior man,
Just the market. Yes. So I try to do my matter. If they get me, just the no follow. No, I no follow. Follow. Yeah, yeah, happen now. You myself, I don't know if you I don't know. I want. Don't mind, relax out. But
Give free and as the concerning health. Yeah. See, the brand, condom, will forget the tempest people in the street. And they do
Yeah. Okay.
guy. Yeah. I will do it. So, I don't do it now. You take the grass from one place to the other.
I don't understand. That's what they do at there now. What now what's the way with the change use there all the time? What's it going change?
As you use them now, eh? HIV dey show for face. HIV dey show for face. They dey write down for face. As soon as don him na guy you cheat, you dey show yourself. So as I dey talk, as you carry am chew, the next person carry am chew. If you get HIV, you don check your HIV, you don do HIV test before. Nothing is wrong. You see, you know, so make it go. Now everything 3 months, HIV test on the office. We come our office now, so we dey free condoms. That's everybody touch. What the woman hold, even the yash cream self, they call they go to call it lubricant. The hair, test for everybody. Yeah.
How far now? You see that I go collect that no good. If you can scratch, I go scratch this afternoon. 3 hands. You can be condom again now. No, as the thing, you can be condom again. Now skin to skin, na any better part.
They pass from one person to the other.
I know they do all this thing.
The person scratch now. No, I not check this stuff.
I don't check.
You know what
I think they bring this small scratch this afternoon. Now they bring all this one.
Now you scratch. Take small break. By the time
but which one? Allow me make I scratch my scratch. Because you cannot be your babe so loaded to scratch this hot afternoon. Quite okay.
No, mama, right?
Okay, like this now, they go back to 5 now. Like this, your man. Don't go allow now. My things is why you scratch my woman.
Office, get medicine we take every day. That medicine will help you the HIV no go fit. Yes, that one they call that one, which is pre-exposure prophylaxis. Then one way you go take, maybe say that one, even if say it was smart, you get to this spot or you take it up. That was yes. Now, go hospital, they do me test, give me that medicine. You no go allow HIV to affect me. As far as I take on within 72 hours, and big game.
I go need take come out.
See all this one talk here. If both condom, where they call lubricants. So now, I don't dey go back office. I just come office man, and they go back office. Maybe tomorrow, people will call here, come for you on a test. And then they go office. And they follow. Yeah.
Before we continue, I would like to speak on behalf of IH appearance. So,
Thank you. Thank you. Can you just set up for the panelists? For the audience we have here, our panel discussion comes to an end. I want to express my gratitude to all our distinguished panelists and the invaluable contributions that they have made, the insights that we have gotten from this engagement. Seeing that community engagement in middle and spiritual programs has helped to scale up services in River State, and of which we have seen a lot of improvement in our community prevention programs. So throughout our discussion, we have been able to summarize everything that we talked about today, and we have been able to explore strategies for reducing stigma, increasing success of harm reduction services, fostering meaningful collaboration with local communities. Your expertise has also brought light in the importance of building trust and tailoring services to diverse needs and advocating for the supportive policies. I want to thank all the brilliant panelists that are here. Thank you so much for your brilliant discussions and even for the questions that came from the audience. There are a lot of questions coming on the online also that we're seeing, and we'll be attending to them also as well. Thank you so much for attending this session. Thank you. Thank you. Thank you.
That brings close to the session, and then a group photograph of the panelists. Yes. So thank you for listening. We wish you a safe trip back to your hotels and your homes. Good evening.
Thank you.